Madam, we are live now. Shall we start?
Okay, yes, let's start, please. Okay.
So, good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's another very interesting topic on a new aspect in acute urinary tract infection. And our guest speaker is Dr. PROPHYLACTIC, madam. It is now, this is the Shield Connect platform. It's a knowledge sharing platform of Shield Healthcare. We have this blog section. You can find different blogs written by many eminent doctors across India in different topics as well. And these are the past webinars already conducted for last 2.5 years in our platform by many eminent doctors across India. And apart from that, we have many awareness page that is PCOS, GDM, menopause, immune booster, COVID-19, and thyroid awareness page tool we have. And in each and every section, you can find all the related information. Like if you are moving into this PCOS awareness, you will find all the related talks related to this PCOS by many, and this talk is available in many regional language. As you can see, that is Hindi, Telugu, English, Malayalam, Kannada, and many more. And apart from this is the menopause awareness blog. Here you can find all the related information related to the menopause. Likewise, this is the gestational diabetes blog. So this section also you will find many talks on GDM, and the most important thing is our key opinion leaders. So presently more than 500 doctors are currently supporting us this knowledge sharing initiative of Shield Healthcare. So now it's time to start the session with madam, and it's my honor to introduce madam. Madam is a senior and a veteran gynecologist and obstetrician for last 38 and a half 38 years experience, aiming to extend her love to serve the community and with the skills and knowledge. And apart from that, madam is worked as a senior resident in Narendra Mohan Hospital, Ghaziabad, as a superintendent and senior gynecologist in Janaki Devi Hospital, Agra. Madam is currently associated as a senior consultant in Dixit Hospital, Agra, and she already participated in many activities in FOXI, many webinars in terms of workshop, other conferences, national and international conferences. Apart from that, madam is the life member of IMS and AOGS, and in terms of interest, high risk obstetrics and infertility. So in this short introduction, I request madam to take over the session, and meanwhile, I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this emerging topic with madam. So thank you very much, madam, once again for your valuable time in our platform Shield Connect, and over to you, ma'am, for further points. Thank you very much.
Okay, thank you so much, Suman Sir, Shield Healthcare Unit, and Ms. Tulika ji. I'm very thankful for giving me this platform. Thank you so much. Now we'll start the new aspects in acute urinary tract infections. Very good evening to everybody. नहीं आ रहा है इसको इधर करो थोड़ा सा इसको स्क्रीन को थोड़ा सा बस yes. Now about epidemiology, UTI are the most common bacterial infections, the most common cause of nosocomial infection. Women make a significant proportion of UTI, suffers with annual incidence of 12.1%. Peak incidence of UTI in women occurs between the age of 20 to 40 years. 20 to 30% of the women who have a UTI will have recurrent UTI. UTI is diagnosed in women by presence of at least 1 lakh colony-forming units in pure culture of voided clean catch urine. Recurrent UTI are caused by the either re-emergence of bacteria from a site within the urinary tract, that is the bacterial persistence, or new infection from bacteria outside the urinary tract, that is reinfection. Recurrent UTI is defined as 3 episodes of culture confirmed UTI in the last 12 months or 2 episodes in the last 6 months. This one. Now, what are the risk factors? Women, they have infections tend to occur, short urethra, frequent sexual intercourse, spermicidal creams, and diaphragms are the main risk factors for the recurrent UTI. Menopausal women have decrease in estrogen, which leads to thinning of urinary tract, which increases susceptibility to bacterial infections. This happens because steroid receptors have been identified in the mucous membrane of urinary bladder and vagina. Estrogen plays an important role to maintain the epithelium of the vagina, urinary bladder, and urethra, deficiency of which produces atrophic epithelial changes in these organs, which may cause dysuria. Pregnancy does not increase the risk of getting UTI, but it can increase the risk of developing a serious infection that could potentially harm the mother and fetus. But some aggravating factors during pregnancy are there is a stasis of urine in the bladder that causes the multiplication of the bacteria, and so influx or infected urine in ureter and renal pelvis due to laxity of vesico-ureter sphincter due to edema. Now, what is the pathogenesis? The interaction between the bacterial virulence and host defense factors can ultimately result in UTI. More virulent bacteria are necessary to infect healthy hosts with normal urinary tract, whereas less virulent bacteria may easily infect compromised host. The cause of UTIs in women is usually colonization of vagina and urethra with bacteria from the intestinal tract. The initial step in the pathogenesis of UTI is bacterial adherence to urothelium by pili. Pili are filamentous adhesive organelle in uropathogenic strains of E. coli. Bacterial colonization causes a host inflammatory response, which includes neutrophil influx followed by apoptosis and exfoliation of bladder's epithelial cells in an effort to get rid the bladder of bacteria. Now, this is the picturization adhesion on pili attached to specific epithelial cell receptors. Now, what are the pathogens in uncomplicated UTI? Most common etiologic pathogens in outpatient with uncomplicated acute cystitis may be gram-negative or gram-positive. Gram-negative bacteria are Escherichia coli in 50 to 80%, Klebsiella species 6 to 12%, Proteus species 4 to 6%, Enterobacter 1 to 6%, and Morganella species 3 to 4%. In gram-positive, Enterococcus species 2 to 12%, coagulase negative Staphylococci 5 to 15%, and group B Streptococci 2 to 5%. Now, what are the routes of infection? There are three routes of infections: ascending, hematogenous, or lymphatic. Ascending is the most common route of infection. The organism from the anorectal region, lower vagina, and vulva gain access to the urethra and thence to the bladder and kidneys. Hematogenous spread involving the kidneys from the intestine or septic tonsil or septic foci anywhere in the body. Then lymphatics. Lymphatic spread is either from the adjacent ascending colon or genital organs like cervicitis. The kidneys may be affected from the bladder through periuretral lymphatics. Now, there are host risk factors in pathogenesis. The predisposing factors in pathogenesis are behavioral like sexual activity, diaphragm use, spermicidal use, and antimicrobial use. Now, functional is urinary obstruction, urinary incontinence, urinary calculi, or catheterization. Anatomical may be congenital anomalies. Hypoestrogenic states as in postmenopausal women when the defense of the bladder and urethral mucosa is diminished. Immunocompromising disorders like diabetes mellitus or HIV and genetic factors. Risk factors differ in pre- and post-menopausal females. In sexually active premenopausal females, risk factors are frequency of sexual intercourse, spermicidal use, age of first UTI. If it is less than 15 years of the age, indicates more risk of recurrent UTI later on. History of UTI in the mother, genetic factor, or long-term environmental exposure. In postmenopausal women, risk factors are either vesical prolapse, incontinence, or post-voiding residual urine. Now, what are the clinical presentation? Patient may present as a asymptomatic bacteriuria or may present as a lower urinary tract infections. Asymptomatic bacteria, the term bacteriuria is used when the bacterial count of same species raises over 1 lakh per ml in midstream specimen of urine on 2 occasions is detected without symptoms of urinary infections. Nearly 30% of the women with asymptomatic bacteriuria develop symptoms of UTI at a later date if left untreated. This entity is found related with high incidence of urinary tract abnormalities, may be congenital or acquired. Overall incidence during pregnancy ranges between 2% and 10%. And lower urinary tract infection present like urethritis, urethral syndrome, cystitis, or pyelitis. Now, lower urinary tract infections. Urethritis symptoms include dysuria, frequency, and urgency of micturition. Pain is typically scalding during the act of micturition. Urethra is tender on palpation. Pus may be squeezed out from the urethra. Then urethral syndrome is a chronic non-urethral form of urethritis. Symptoms include dysuria, frequency, nocturia, and urgency of micturition. Cystitis, the most common form of UTI. Symptoms include dysuria, frequency, urgency of micturition, and pain. It produces pain during micturition. At the end of the act, there may be suprapubic tenderness. Pyelitis symptoms include aching pain over the loins and fever with chills and rigor. There is frequency of micturition, dysuria, and there may be anorexia, nausea, vomiting. Now, initial evaluation of patient with recurrent UTI. Most women with recurrent UTI do not have anatomic abnormalities and do not need an X-ray. So the assessment should include history and physical examination that include a pelvic examination, pelvic ultrasound for residual urine, midstream urine examination reveals plenty of pus cells, urine culture and sensitivity for documenting that UTI is the cause of symptom, typically frequency, dysuria, and hematuria. Then in blood test, CBC shows the complete blood count, shows the leukocytosis, and renal function test, urea and creatinine level may be raised. Now in chronic or recurrent UTI, more extended protocol is indicated like cystoscopy and intravenous pyelography. Now specialized evaluation for recurrent UTIs. For congenital abnormalities, either CT scan or IVP should be done. If a patient had prior pelvic surgery, then ultrasonography for checking hydronephrosis and hydroureter because of ureter may be caught in scarring due to the stitch or clip during prior surgery. And cystoscopy to check the bladder for the stitches which can form a nidus for stone or infection. Specialized evaluation for UTI continued to be UTI with Klebsiella, Pseudomonas, or Proteus bacteria. Ultrasound KUB is done because these bacteria have urease splitting enzyme that can alkalize urine and may cause the formation of stroboid stones. Kidney stones check non-contrast CT for the stone, evidences of the urinary obstruction. Then pyelonephritis is diagnosed by positive urine culture sensitivity, back pain, and high fever. Now, what is the differential diagnosis of the recurrent UTI? Not all women with frequency, dysuria, and hematuria have UTI. In the case of recurrent UTI, especially with negative cultures, a urological and gynecological evaluation should be performed in order to exclude the bladder cancer, obstructive problem, detrusor failure, vaginal infection, genital infections, interstitial cystitis, or neurological disease. Now, what are the complications of recurrent UTI? Maybe acute papillary necrosis, overwhelming sepsis syndrome with shock due to loss of vasomotor tone, capillary leak, or impaired myocardial performance. There may be perinephric abscess also. Now come to the treatment of recurrent UTI. Now, primary treatment of recurrent UTI should be guided by culture and sensitivity. Commonly used antimicrobials that act on gram-negative uropathogenic organisms include trimethoprim and trimethoprim with sulfamethoxazole, fluoroquinolones like ciprofloxacin, levofloxacin, norfloxacin, ofloxacin, and moxifloxacin. Then nitrofurantoin, beta-lactam penicillins, amoxicillin, ampicillin-client compound, cefadroxil or cefodoxin, and there may be duration of treatment of 7 to 10 days increases the rate of eradication and minimizes resistance to drugs. In reinfection, the appropriate drug is to be continued for at least 2 weeks. This is to be followed by nitrofurantoin 50 mg or norfloxacin 400 mg daily for 4 to 6 months. Women with recurrent UTI in pregnancy, they should undergo imaging of upper urinary tract 3 months postpartum. In postmenopausal patients, estrogen plays an important role to maintain the epithelium of vagina, urinary bladder, and urethra. Estrogen deficiency produces atrophic epithelium in these organs, which may lead to dysuria. Considering the risk, hormone therapy should be used for the lowest effective dose and short period of time. The hormonal therapies which are used are the low-dose oral conjugated estrogen, 0.625 to 1.25 milligram per day. It is effective and has got the minimal side effects and used for the women who have had hysterectomy. Then subdermal implants, 17 beta estradiol implants are available and also suitable for the patients post-hysterectomy. Then vaginal creams, conjugated equine vaginal estrogen creams, 1.25 milligram per day is very effective, especially when associated with atrophic vaginitis. It reduces urinary frequency, urgency, and recurrent infections. Now, prevention of recurrent UTI. The following guidelines are prescribed in an attempt to prevent the infection to lower urinary tract. To maintain the proper perineal hygiene, this consists of cleansing the vulval region at least daily, wiping the rectum away from the urethra. Prophylaxis of coital infection, to void urine immediately following coitus, single dose of nitrofurantoin 50 mg following coital act is an effective means of prophylaxis. This is helpful in women who have history of postcoital exacerbation of infection. Then catheter infection, whatever aseptic measures are taken, use of catheter favors the introduction of infection. Catheter should preferably be avoided. Then bacteriological monitoring of urine should be done periodically and after removal of catheter when an indwelling catheter is used for a long time. Then plenty of fluid intake should be encouraged. Now, management. Now we have management's principles, some non-pharmacological therapies and pharmacological therapies. Non-pharmacological therapies have doubtful role and they include like adequate fluid intake, voiding after sexual intercourse, ingestion of cranberry juice, eating yogurt, lactobacilli cultures, vaginal application of lactobacilli, and avoiding constipation. Now, pharmacological therapies, the main points: first, to isolate the organism and drug sensitivity prior to antimicrobial therapy. Second, to administer effective drug for an adequate length of time, 7 to 10 days. And third is to prevent reinfection. Now, prophylactic antimicrobial therapy. It may be a continuous prophylactic antimicrobial therapy, or it is a postcoital antimicrobial therapy, or it is a self-start antimicrobial therapy. Now, what is continuous prophylactic antimicrobial therapy? One effective approach for management is the prevention of infection by use of long-term prophylactic antimicrobials taken on a regular basis at bedtime. It is not known which antibiotic schedule is best, optimal duration of prophylaxis, incidence of adverse events, recurrence of infection after stopping the prophylaxis, and what is the treatment compliance. The choice of antibiotics is either trimethoprim, cotrimoxazole, or nitrofurantoin can still be considered as the standard regime. In case of breakthrough infection due to resistant pathogens, low dose of fluoroquinolone may be used. During pregnancy, on oral first generation cephalosporin is recommended. Antimicrobial agents for the genitourinary pathogens are in complicated UTI like E. coli, enterococci, pseudomonas, or staphylococci. Choice of antibiotic will be fluoroquinolone, aminopenicillin, or third generation cephalosporin or aminoglycosides for 3 to 5 days after the patient is afebrile. This is the list of all antimicrobial prophylaxis regime for women with recurrent urinary tract infection. For the continuous prophylaxis, trimethoprim sulfamethoxazole 40 to 200 milligram daily, trimethoprim sulfamethoxazole for 3 days to up to 3 weeks, then nitrofurantoin 50 to 100 milligram, cephalexin, cefaclor, norfloxacin, ciprofloxacin, and sinoxacin. Then postcoital and prophylaxis, single dose only, trimethoprim sulfamethoxazole, nitrofurantoin, cephalexin, sinoxacin, ciprofloxacin, norfloxacin, and ofloxacin. Then acute self-treatment, trimethoprim sulfamethoxazole, ciprofloxacin, norfloxacin. These are the prophylactic regimes. Now, postcoital antimicrobial therapy, it is an alternative prophylactic approach for women in whom the episodes of infection are associated with the sexual intercourse. So, same drugs can be used in the same doses as recommended for continuous prophylaxis. This is self-start antimicrobial therapy. It is suitable for the management in well-informed women in whom the rate of recurrent episode is not too common. This is not prophylaxis, but it is an early treatment. It has emerged in an effort to decrease overall antibiotic usage. It relies on patient's intelligence and recognition of UTI, and patient takes same antibiotic for 2 to 3 days. Now, efficacy and side effects of prophylactic therapy. Number of the patients with recurrent UTI decreased by 8-fold after the prophylaxis. UTI episodes per patient per year is reduced by 95% during this prophylaxis. However, prophylaxis does not appear to modify the natural history of recurrent UTI or exert a long-term effect on the baseline infection rate. After stopping the prophylaxis, even after extended periods, approximately 60% of the women will become reinfected within 3 to 4 months. Side effects of prophylactic antimicrobial include vaginal and oral candidiasis and GI symptoms. Now, recurrent UTI in pregnancy. Women with bacteria in urine during pregnancy should be put on prophylaxis till delivery, either penicillin or first generation cephalosporin. Other option for patients who are allergic is nitrofurantoin. Women with bacteria with no symptoms and who are not pregnant do not need to be treated with antibiotics. Some other drugs which are used like pyridium and flavoxate. I don't have this slide. Can I speak? Hello. Yes. The pyridium is a benzopyridine hydrochloride. It is used to relieve the symptoms caused by the irritation of the urinary tract, such as pain during urgency, etc. It is a drug that works as a painkiller to soothe the lining of the urinary tract. It takes about 45 minutes to 1 hour to relieve the symptoms. This is about the pyridium or benzopyridine hydrochloride. And one more drug I want to speak about is the flavoxate hydrochloride or Urispas. I don't have slides, sorry. Flavoxate is a smooth muscle relaxant. It works by relaxing the muscles in the bladder. Flavoxate can start to work as quickly as 55 minutes after taking the dose. Dose is 1 tablet 3 times a day. Flavoxate is but usually it has some common side effects are those of the parasympathetic stimulator like dryness of mouth, headache, constipation, etc. Urispas tablet, these are the synthetic urinary tract spasmolytic. Now, some other medications are used in the urinary tract infection that I'm going to speak is cranberry. Cranberry is a North American native. Cranberry was a popular treatment of UTI prior to the introduction of antibiotics and continues to be used widely for this purpose. Cranberries or proanthocyanidin can inhibit the attachment of bacteria to the epithelial lining of the urinary tract. In vitro studies have observed potent inhibitor of bacterial adherence of E. coli and other gram-negative uropathogens. This is proanthocyanidin, a high potent cranberry. Only proanthocyanidin A exerts anti-adherent property, prevents the pili of E. coli attaching to the uroepithelium, flushes E. coli, thus it prevents the E. coli reservation formation and prevents the recurrence. Cranberry has direct antibacterial activity. Cranberry may offer an alternative methodology to antibiotic prophylaxis. Effect on type P fimbriated E. coli was observed to be specific to cranberry. 400 mg per day shows the reduction in recurrent UTI. In one uncontrolled study, more than 50% of the patients had a positive clinical response in UTI. Now, second is D-mannose. D-mannose is a sugar monomer of also-hexose series of carbohydrates. Mannose is a C2 epimer of glucose. D-mannose prevents binding of type 1 pileated E. coli to the human bladder cell line and reduces both adhesion and invasion of the E. coli. It significantly reduced the bacteriuria within 1 day. Patients who were treated daily with D-mannose, 94% reported symptoms improvement. So the right combination was alternative medicine review suggests the use for cranberry and D-mannose as a natural option for the management of UTI. At the same time, are also suggested to alkalinize the urine and reduce the dysuria. Now, third one is ursolic acid. It is a powerful anti-inflammatory and analgesic. It inhibits the pro-inflammatory cytokines TNF-alpha and prostaglandin E2. Anti-inflammatory effect comparable to indomethacin. A powerful NSAID, a rapid relief from the pain, powerful antioxidant, and prevents tissue damage and inflammation. Now, evidences for ursolic acid are in the Journal of Applied Pharmaceutical Science that anti-inflammatory activity of fractionated excerpts of Salvia officinalis is a topical anti-inflammatory activity of Salvia officinalis that leaves the relevance of the ursolic acid. So this is the single prescription for burning micturition, pain, and recurrence is the UTI flush. It includes ursolic acid, high potent cranberry, D-mannose, and potassium magnesium citrate. The dose is 1 sachet in acute painful UTI, 1 sachet daily for 15 days, and in recurrent UTI, 1 sachet daily for 30 days. For burning micturition, pain, and recurrence in UTI, rapid pain relief with UTI flush, ursolic acid developed by Spain, natural anti-inflammatory and analgesic, more powerful than indomethacin, relieves the burning micturition, potassium magnesium citrate, and novel alkalizer, and prevents the recurrence. High potent cranberry and D-mannose have proanthocyanidin 50% and prevents adhesion of the E. coli. Now, latest is the immunological therapy for the recurrent and acute UTI. Now, microbial lysates of E. coli have been introduced for the treatment of acute and recurrent UTI. The product Libitum, the microbial lysates, has the following properties and benefits. It reduces the colonization of vagina and bladder with uropathogen by activating body's natural defense. It reduces recurrent UTI effectively, also reduces antibiotic consumption and is well tolerated. In acute UTI can be initiated concomitantly with antibiotic in order to prevent further infection. Thank you so much. Thank you. That's all about the recurrent UTI and infections. Thank you for
Thank you.
Thank you all Shield Care Unit and my participants for the patient sharing.
Thank you very much, ma'am, for this nice presentation and our valuable discussion on this emerging topic. Just give me 1 minute time to check, ma'am, is there any question in our dashboard?
Okay.
So, ma'am, the first question is, what is the difference in the treatment protocol in case of early pregnancy UTI and in the late stage cases?
In pregnancy, there should be no difference. Same drugs to be continued.
Same drugs to be given.
Nitrofurantoin is also safe, and other drugs, the Palaxin. Culture sensitivity, according to the culture and sensitivity, we have to give the medicines Whatever the safe. I have mentioned 2 or 3 drugs, nitrofurantoin or cephalosporin probe
Yes, ma'am.
on the patient's symptoms, what she has. Because in early pregnancy, they are usually burning and increased frequency. In late pregnancy also, they have a very increased frequency. So,
Okay, ma'am. Thank you. And another question is, ma'am, what is your practical observation on this using ursolic acid or cranberry extract for this UTI?
yes, it is a good. But in compliant with the antibiotic, it has a very good effect. So we
So
can
can it be?
use the
Mhm.
dose of antibiotic, the duration of the antibiotic is reduced, and they can be continued for a long time also.
And madam, just want to know one thing. Always, it can be used as an adjuvant therapy, or can it be prescribed alone to reduce or to cure this urinary tract infection? What is your opinion?
See, if the infection is of severe and acute type, then we have to add the antibiotic. But if it is a chronic type, then it can be used all alone. Otherwise, in the acute infections, it is an adjuvant with antibiotic.
Sure. Thank you very much, ma'am. I
Okay.
could see one question Dr. Shima madam asked that what to do for surgical menopause.
For surgical menopause,
Yes,
yes,
ma'am.
in menopause, whatever it is, surgical menopause, the same we have to add some estrogen that I have mentioned 2 or 3. We have to add some estrogens along with it.
And another question, madam also asked that what is for recurrent UTI? Please suggest.
For recurrent UTI, for women,
What I guess actually the question is what is for recurrent UTI? Please
yes,
suggest. I guess maybe madam want to ask that what are the drugs or
what are the,
something or the protocol? Yes, that is
yes,
effective for this
for
treating
the,
recurrent.
yes, for the recurrent UTI, we should start for it. It should be a for long treatment. Like nitrofurantoin, we have to give it for the 3 to 6 months, 3 to 4 months, depend on the patient what it is, and what is the antibiotic. Low dose proquinolone we can use for a long time. So whenever there is a recurrent UTI, we have to give a long protocol. So nitrofurantoin is very safe and low dose fluoxetine group, ciprofloxacin, norfloxacin. Norfloxacin is the safest. Okay.
Thank you very much, madam. And another question is how to treat urinary incontinence.
Urinary incontinence. That is the
Yes.
different. Incontinence may be because of the, if there is a laxity of the urethral sphincter, then we give the duloxetine. And if it is a stress incontinence, then we give the other things. But in these cases, duloxetine is given. Dulotonin tablet, 1 tablet twice daily for the urinary incontinence. Duloxetine.
So how long can it be prescribed, madam?
Initially, we start with the 1 tablet twice daily, then seeing the response, and later on we have to reduce the dose. We can continue it for a month together, but in the reducing dose and see the side effects, whatever the patient. In between, we have to check up the all urinary function, kidney functions, urine test. These are all the procedures. But maybe what is the cause of incontinence, that depends on. If it is an old age patient incontinence, then we have to give some physical exercises, physiotherapy also.
Thank you very much, madam. So, madam, I could not find any other question. So, if you allow me, then we can conclude this session. Meanwhile, I want to say that Dr. Shima, madam, also wants to conveys her thanks to you.
Okay, thank you
And
so much.
yes.
You're welcome.
And it was a very nice session and a valuable discussion also. So in future also, I look forward for some valuable session with you, madam. So thank you very much
Thank
for
you.
your valuable time in our platform Shield Connect. And in future also, I'll be more interested to take a good session with you. Thank you very much, madam.
Okay, thank you so much. Thank you, Shield Unit Healthcare, Tulika and Suman Saha, please. All the Thank you so much. Very good evening.
Have a good day, ma'am. Yes, ma'am.
Okay, thank you. Thank you.